I'm Dr. Nilsa Gutierrez. I'm the Chief Medical Officer at the Centers for Medicare and Medicaid Services here in Region 2. We are based in the federal office building, but our responsibility is New York State, New Jersey, Puerto Rico, and the U.S. Virgin Islands. And much of my responsibility and role really is to provide the program staff, those that oversee the Medicare program, Medicaid, Child Health Insurance Program, and survey and certification with clinical guidance and advice. We're also very, very much focused on quality of care, and probably for you in the audience who are from long-term care, home health, and of course in hospital settings, you know CMS because of our role in survey and certification, because we are responsible for overseeing that hospitals and all healthcare facilities that participate in the Medicare program are able to, we assure that they meet all of the conditions of participation for the Medicare program. So I want to take this opportunity to thank Dr. Beverly, who has done a yeoman's job of really pulling us together and assuring that those of us former interns and residents who are in practice as well as in policy meet you and be able to offer our advice and our commitment to continue to work with H&H on the many, many challenges you have given the diversity of the community of people, patients that you care for. And I want to say here in public to you, Dr. Beverly, that certainly CMS in Region 2 is committed to seeing how it is that we can, in a very concrete way, provide support to you and the staff throughout the hospital systems. So with that, I wanted to just take a few minutes to provide you with a list of what the scope and responsibilities are of CMS. And as you can see, we are the largest purchaser of healthcare in the world. And combined, Medicare and Medicaid pay approximately 1/3 of national health expenditures. That's about $800 billion. The CMS programs currently provide health care coverage to about 105 million people, basically 1 in 3 Americans. And through various contractors, CMS processes over 1.2 billion in fee-for-service claims. So you can imagine the level of not just responsibility, but the level of activity in this agency and the position it is in to really oversee quality of care and services across all Medicare beneficiaries. This is important because we're really trying to accomplish, and certainly since the Affordable Care Act was signed into law by President Obama, we have been working very, very hard to really understand who the Medicare beneficiary is, what is the profile of the beneficiary, and how to collect information that really gives us much more than race, white and non-white, white, black, and Hispanic, and not more detail. So we have been trying to, I would say since 2003, really been working to move care in a very, very different direction. We want to move from the very traditional approach of listening to a patient's chief complaints and reasons for visiting, for that to determine care. That's not what should be determining care. We should be looking systematically at the person's socioeconomic status, what their work environment is, what their family history is, what their immediate needs are in terms of their chief complaints, but really create a plan of care, something that where we are proactive and certainly where the physician uses evidence-based guidelines. This is very easy to say, but changing clinician behavior is extremely difficult. And since 2003, CMS has been using different approaches to try to accomplish that. First, it has used payment penalties. Certainly, hospitals were the first to be required to report quality measures, and that, of course, has extended to nursing homes, home health, hospice, dialysis for people with end-stage kidney disease. It's also included reporting requirements for physicians. And while a lot of this has caused angst amongst the clinical community, nevertheless, what we're trying to accomplish is move from a fragmented care to coordinated care. One gap that we all know exists is that we haven't been able to cross the bridge between the healthcare community and the non-medical community-based services that are essential and really are the continuity and the thread that can really keep people out of the hospitals and can keep people healthier. One important, I'm not sure if many of you are aware of the Center for Medicare and Medicaid Innovation, also known as the Innovation Center. But the Innovation Center has received under the Affordable Care Act $1 billion over 10 years to really test models of care and really focus on primary care transformation, on episode-based payments, on accountable care, looking at the dually eligible, and looking at where states can focus on individuals who are high utilizers of care and services to really understand why. So there are many state initiatives. But the whole point is to really move to a system where there's better care, smarter spending, and healthier people. This chart is of value because it gives you, and for those of you in the back, I know you cannot see this, but on the left there are diagnoses, and along the x-axis are percentages. If you look at the purple means that the beneficiaries who have heart failure, look at about 60% have 5 or more coexisting conditions. And when you look at the purple and you see that for conditions like COPD, chronic kidney disease, stroke, and heart failure, and certainly Alzheimer's, you see that that those individuals, that a large percentage of those beneficiaries have 5 or more other conditions that have to be managed, and that means that care coordination is central to achieving better outcomes. The other is that someone else showed this slide, and I believe it was Dr. Price, and really what it's showing is that the leading causes of death over the time that many of us were in training has changed substantially, where heart disease and stroke really we've made great progress in that area. But I want to bring your attention to Medicare beneficiaries. We have the data for 50 million beneficiaries. That's a lot of people that we can learn something about. And the Affordable Care Act actually allowed us to begin to collect information by race, ethnicity, sex, primary language, and disability status. This is very important. This was signed into law in 2010, and by October 2011, the Secretary of Health and Human Services had already signed on to this new standard for data collection for all government-funded programs. And so to just get a better sense of what the beneficiary is, so I can move very quickly here, you can see that the per capita income among Medicare beneficiaries by race, ethnicity in 2014 really shows that amongst Black African Americans, it was 16,000 compared to 27,000 for whites, and you can see the numbers there. I think that they're projecting clearly. Similarly, savings is important. You can see the market change and difference between the Black African American savings. These are per capita savings, so the average amount that a beneficiary would save is $12,350 versus almost $92,000 for whites. Also, with respect to language and communication, you'll see here that 4 million beneficiaries, or 8%, have limited English proficiency. Those are the languages: Spanish, Chinese, Vietnamese, and Tagalog are the most common languages. 4 million are blind or have low vision, and approximately 8 million are deaf and hard of hearing. But the healthcare system doesn't quite adapt to people's disabilities and needs, and this is an area where there are huge gaps. When you compare the Medicare population to those in the health insurance marketplace, those that receive insurance through Obamacare, you'll see that 90% of the selected English as the spoken language, and only a very small percent chose Spanish. And of the Asian language, unlike the Medicare beneficiaries, you'll see it's Vietnamese, Chinese, Korean. So they're very, very different populations, and we try to work very hard to understand and see how it is that we can work to make our materials, our information about benefits and services available in all languages. So I decided to select about 6 diseases so that you can see what the differences are across racial ethnic groups. I'm not sure how that's projecting, but the middle bar, 37%, is the prevalence of diabetes amongst Medicare beneficiaries in 2012. So the Black African American population is 37% compared to 38% in Hispanics, which is the highest. I have to move very quickly. Hypertension. Here you see that the Black or African American, it has the highest prevalence of hypertension when you look at all beneficiaries. These beneficiaries are in Medicare fee-for-service. These are not beneficiaries in Medicare Advantage. That is an entirely different group. And right now in the United States, Medicare, about 30% of beneficiaries are enrolled in a Medicare Advantage plan, Medicare Managed Care. But in New York City, it's as high as 55, 60%. So a lot of beneficiaries are in that setting, and I just want to bring a few things to your attention related to that. This is stroke, and once again, the African American population has the highest rate, 6%, compared to other beneficiaries, white, Hispanic, Asian, and American Indian Pacific Islander. Chronic kidney disease is a huge problem, and as you can see, beneficiaries in this group, the Black African American has the highest rate of chronic kidney disease, and one can understand that hypertension and diabetes are the most common causes. And of course, our challenge has been to try to get clinicians to identify people early with renal insufficiency and get them into care as quickly as possible and monitor them closely to prevent kidney failure. I have not been able to identify one institution or one entity that's really been able to do a successful job with that, and maybe that is something that it's a project for us to work on. With respect to heart failure, again, Medicare beneficiaries in fee-for-service, you'll see here the Black African American has 17% prevalence rate compared to other groups. Alzheimer's disease, again, when you look at beneficiaries, you'll see that African Americans have the highest rate of prevalence rate of 15%. And depression. Once again, the Black African American has 23%. So this is a very big deal. And we just need to be aware that, and certainly as mentioned in a previous presentation, HIV/AIDS also the highest prevalence rate. So there's a big job to do. Dr. Beverly is pushing my button and telling me to hurry up. I want to show you 2 more slides because they're very important. This mapping, it is a mapping tool that was developed by the Office of Minority Health. And I'll make that available to Dr. Beverly so she can make it available to you all. But you can actually drill down with your cursor down to the county level and look up as many as 58 different conditions, hospitalizations, readmissions, multiple chronic diseases, and compare it by race, ethnicity, geography. It's all there. And so this is a really important tool for you to have. The other is that CMS released data from Medicare Advantage plans. I will also make that available to Dr. Beverly so she can make it available to you. It has HEDIS and CAP scores for different racial ethnic groups at the individual Medicare contract level. So if you're working with 5 or 6 Medicare Advantage plans, you can see how they are providing care and services, if they are in fact providing the care that they need. This is again the Medicare Advantage penetration, so you can see how high it is. That's the last column. I want to show you, finally, I'm going to move ahead because there is technical assistance. This is hands-on, in-person technical assistance to institutions to really address disparities, how to look at your own data, how to use CMS data so that then you can come up with solutions. And these are all the resources that are available, and you can be walked through this so that you can understand how it can apply to H&H. About the opioid epidemic, I want to bring one point to you. 1 in 3 Medicare beneficiaries have received an opioid prescription at some point, and this was first noted in 2011 by the General Accountability Office. This is a heat map, and I want you to be aware that this map allows you, with your cursor, to go down to the zip code level to see who, where, or the frequency of opioid prescriptions are being, how many prescribers there are that are overprescribing opioids. So that's down to the zip code level. So you can control and you can see what's going on in your community with respect to the opioid epidemic. I'll stop there because she won't let me talk any longer. All right, thanks.